Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the Southwest Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a Haemareg.
And let's get started on today's topic.
From basics
to brilliance. Right, hello David, how are you today?
Very good.
Ready to learn
for some
more
heparin action?
Excellent, yes. Yep. Good. So, I thought today we'd talk all about heparin. So all things heparin, from how it works and how we can monitor it and how we use it and for what indications. So we'll hopefully be covering everything from the practical hemostasis side to the clinical side of heparin use. And obviously it's a drug we use a lot. So I think hopefully this will be really helpful for a lot of people listening at home.
Yeah, truth be told, I prescribe it all the time when someone says to me VTE prophylaxis and things like that.
Yeah.
And, full disclosure, I don't really know a lot about it. So it might be a bit heavy today and me attempting to be inspired by our listeners' voices and ask the questions that maybe people have thought about.
Yeah, exactly. Okay, well, that's great. I thought we should start first of all with just to say that there's a really good BSH guideline on monitoring of anticoagulants in the lab, which I do think is a good read for anyone who wants to sit part one. And I do believe that was an essay question for part one recently. Yeah. So
insider knowledge.
So it's very relevant, basically, and it's definitely a really good read. We should probably start more generally, though, with thinking about situations in which we would actually need your anticoagulants.
So, I mean, here's the scenario, which I'm sure you've run into many times, and we have as well, is that you get someone in who's usually quite a large person.
Okay.
They have got a query PE, you're sending them for a CTPA, they weigh 140 kilograms, and you go to the trust guidance and it says, contact your local friendly hematologist and do some kind of 10A study as well.
Yeah.
Maybe so if I'd phoned you up and said, I've got this guy, he's had a suspected PE, he's 140 kilograms.
Yeah.
What would you say, and what's your thought process? That would be helpful.
Yeah, that's such a common case. I don't think I've ever had an on-call day where I haven't been phoned about this in some form or another. But basically, we will talk about that because that is one indication in which monitoring of an anticoagulant is actually really helpful, because there is limited evidence in terms of what to dose people with low molecular weight heparin, both for prophylaxis and treatment. Once you're getting into the realms of sort of above 120 kilograms. And so that's why then doing an anti-10A level can be really helpful to see whether you're in what is considered the therapeutic range. And we'll go into the anti-10A test that you were talking about. So you've mentioned one reason why we might want to measure someone's anticoagulant level in their blood, which is extremes of body weight. So both obesity is one, but also really low body weight, so less than 50 kilograms, sometimes would also make us want to measure how much actual anticoagulant is on board for that patient. Any other scenarios you can think of where you might want to, test and find out how much anticoagulation is in a patient?
I think we mentioned in our last podcast about people that were on bypass in surgery?
Okay. Mm-hmm.
I don't fully understand what you said then, but I knew you mentioned it and it sort of stuck with me somewhere.
Yeah, absolutely. I mean, that's more for unfractionated heparin, and we're going to talk about the differences between low molecular weight heparin and unfractionated heparin in a minute. But yes, unfractionated heparin needs monitoring because it's very variable in terms of what dose causes the amount of anticoagulant effect, both within that individual and between individuals as well. So it really does have a high monitoring requirement. But what about other indications for drugs that you wouldn't normally need to monitor, like apixaban or low molecular weight heparin.
Yeah, I've got nothing.
No, that's fine. When I'm presented with these sorts of questions, I tend to try and think about it in a sort of more systematic way of thinking, okay, so first of all, I've got to take the tablet or take the injection. So assessment for compliance can be a reason that we might want to find out how much anticoagulation is in a patient's blood. And then secondly, taking the tablet or taking the injection, so suspected overdose might be another indication. If you're using a non-standard dose for some reason, some clinical reason, then you might want to do a level and find out what's going on in terms of anticoagulation in the patient's blood. Patients that, if they're taking an oral anticoagulant and you're worried about absorption, then that can be a situation in which you might want to find out how much anticoagulant's in the patient. And then renal impairment is a really big one as well. And I would say probably the two most common ones clinically that we end up doing tests to see how much anticoagulation is in the patient's blood is the extremes of body weight and renal impairment. Sometimes you might also do it if you have a patient that comes in with an acute severe bleed in which you're considering reversal, but you don't know when they last took their dose. Or likewise, if they needed emergency surgery or an invasive procedure and you don't know, you're unable to establish when they last took a dose of a drug that you know that they do take for anticoagulation. And then in children, we would also, we do routine monitoring, even of things like low molecular weight heparin, because their pharmacokinetics of how they handle the drug can be quite different. And finally, sometimes in pregnancy, in certain high-risk situations, we would also want to know how much anticoagulation is on board. And just to start, before we talk about anything any further, if I ever do say the term target range or what the target is, what I should really be saying is expected range, because it's difficult to talk about these ranges in terms of levels of anticoagulants as a target when actually it's more like there isn't the evidence necessarily to clinically back it as being this is the target. It's more that that's the expected range. So expected range is a more suitable term. Right, so I thought we'd start with talking about heparin just more generally. So as a molecule, do you know where it comes from?
So from what I understand, it's in mast cells that are
Yes.
in sort of the liver and intestines. Is that
Yeah.
about right?
Yeah, that's right, exactly. So heparin is a naturally occurring glycosaminoglycan. And so it's a polymer which in normal health has a natural anticoagulant function. And it is made in the mast cells, which exist in the liver and the lungs and the intestine. So in terms of a drug that we use in medicine, it's derived from mashed intestines of pigs or cows, basically. And in the UK, we've chosen bovine mashed guts because there's a lower risk of heparin-induced thrombocytopenia than the pig one, apparently. It exists as a range of sizes, David. Okay, so it's not just one molecule, it's a whole spread of different polymers that naturally exist. And because we're not synthetically making it in the lab, we're extracting it from physiology, from gut being mashed up. You've got polymers ranging from a size of 10,000 Daltons up to 50,000 Daltons, so quite a big spread in the size. And do you know then what this unfractionated versus fractionated heparin is, or what the process is?
Well, so what's the difference between the two, or how we sort of identify the different ones?
Yeah, what's the difference between unfractionated heparin and low molecular weight heparin in terms of what it's made of?
So from what I understand, they're similar molecules, but one
Hmm.
has a long tail. Does that sound about right?
Yeah,
And because of the long tail, it can also interact with, is it factor 2 as well as 10A?
yeah,
Something
very
like
good.
that.
Yeah, I'm
Yeah,
impressed you
it's one
know
of
that.
those where I've kind of looked up, I've seen a diagram, but
Okay.
I don't really understand it.
Yeah, no, that's really good. I mean, even more basically than that, this process of fractionation is basically taking the range of sizes of heparin and then siphoning them off into the smaller sized molecules, which makes your low molecular weight heparin, in which you have a range of between 1,000 and 10,000 Daltons, versus your unfractionated heparin, which is a range from like 3,000 to 30,000 Daltons, so much bigger. So the fractionation process is just separating out the heparins based on the size. Okay.
Okay.
And we'll get into why that's important in a minute. So you touched on the mechanism of action for the two drugs. Can you elaborate on that at all?
Not much,
Okay.
if I'm honest.
That's fine.
I'd rather not embarrass myself. I'll let you have that.
No, that's fine. So the mechanism of action, basically, for all of your heparins, one of the main ways in which for both of them, I think it's worth saying that they are not a direct thrombin inhibitor. Okay, so heparin to work very much needs the presence of antithrombin 3, which is a protein that is found in our blood. And when heparin binds to antithrombin 3, that complex can then bind 10A and inactivate it. And it can also, if it's a long enough molecule, which is what I think you were talking about with the tail, so in unfractionated heparin, where you've got your bigger molecules, then it can also bind to 2 because the tail kind of wraps around the antithrombin 3 and binds 2 and can therefore inactivate thrombin as well. So both types of heparin have both anti-10A activity and they also have antithrombin activity. Both are via binding to antithrombin 3, the molecule. Okay. But the difference is that in unfractionated heparin, the ratio of 10A to 2A activity being inhibited is a 1-to-1, i.e. for unfractionated heparin, it's inhibiting as much 10A activity as it is inhibiting 2A activity, okay?
Yeah.
But in the low molecular weight heparin, there's a much bigger degree of anti-10A activity and much less ability to inactivate your thrombin because it's just not long enough to bind that as well, the molecules. So your standard length of molecule is the pentasaccharide sequence, so 5 saccharides, and that's needed for the anti-10A activity, and that's found in both unfractionated and low molecular weight heparin. And actually, coincidentally, fundoparinox is the synthetic pentasaccharide that we use, in like ACS, for example.
Yeah.
But then if your heparin molecule is 18 saccharides or longer, then the tail is long enough to wrap round and also inhibit thrombin. And that's why in unfractionated heparin, you're able to do a 1-to-1 inhibition of both anti-10A and anti-2A in equal proportion. As in low molecular weight heparin, you're mainly doing an anti-10A activity. There is, they say it's probably kind of maybe 2.5 to 4 times more anti-10A activity than anti-2A or antithrombin activity in low molecular weight heparin. But the range exists because different preparations, enoxaparin versus dalteparin versus tinzaparin, they all have slightly different mixes of the size of the molecules, which will therefore affect quite how much anti-2A activity you're able to do depending on the preparation. But in my head, I think of low molecular weight heparin as basically anti-10A activity and unfractionated heparin as being an equal amount of anti-10A activity and anti-2A activity. Does that make sense?
Yes. I'm just trying to work out what would be the clinical implications for that difference if I were to give unfractionated heparin versus low molecular weight.
Yeah, that's a really good question. And to be honest, David, there's no difference in terms of their ability to anticoagulate patients. So they're as effective as each other in many ways. Like they're kind of used interchangeably. But the reason why we might choose unfractionated heparin over low molecular weight heparin in certain scenarios is more to do with the pharmacokinetics of the two drugs rather than whether they affect 10A or 2A activity. But the reason why I'm labouring the point about how much they affect 2A and 10A activity is it allows us, if we understand the mechanism of action behind the two drugs, then it will make it much easier for us to then think, okay, how might we monitor the activity of these drugs in the lab?
Yeah, that makes sense.
Yeah. And it also explains why, when we were talking about the thrombin time last time, it explains why the unfractionated heparin prolongs the thrombin time. But low molecular weight heparin doesn't really do that so much because it's mainly anti-10A activity. So the thrombin time is usually left kind of untouched. And that's why the thrombin
Nice.
time used to be more useful back in the day, looking for heparin contamination, because more people were on unfractionated heparin at the time, because we used it a lot more back then. But now with the advent of low molecular weight heparin, the thrombin time isn't really that useful for picking up heparin contamination because it doesn't pick up low molecular weight heparin. But now it's more, the thrombin time is more useful to pick up other drugs like direct thrombin inhibitors like dabigatran, for example.
Got it.
Cool.
Nice full circle there.
Yeah, exactly. Yeah. I thought this topic led on quite nicely from the previous one for that reason. Yeah. Okay, cool. So that's the mechanism of action for the two drugs. And then you asked kind of how are the drugs different? And I said it was about the pharmacokinetics. Do you know anything about the pharmacokinetics or how they're delivered, unfractionated versus low molecular weight?
So from what I understand, the onset of unfractionated heparin is pretty swift, isn't it?
Yes, yeah, because it's IV, so
Compared,
it's straight in the vein. Yeah.
yeah. And I think you can give both of them subcut, but yeah, unfractionated heparin you can give IV.
Yeah, that's right.
And then I imagine the half-life is it shorter in unfractionated heparin?
Yeah, it is. It's much shorter. And that's really where the clinical utility of unfractionated heparin comes in, because its half-life is only 45 minutes most of the time. So its excretion is by two mechanisms for unfractionated heparin. At a low dose, it's the reticular endothelial system, which results in this very rapid excretion with a half-life of only 45 minutes. So that means within 90 minutes, you've basically gone down to, almost no unfractionated heparin left. So that's a really quick time of offset of action, basically, which is a real clinical use of using unfractionated heparin. At higher doses, you can saturate the reticular endothelial system, and then the half-life does get a bit longer at 90 minutes. But generally speaking, unless we're talking about big overdoses, it's usually a half-life of about 45 minutes, which makes it super useful, okay? Why would it make it super useful? Because you might have a patient that needs to go to theatre, or you might have a patient you're really worried about bleeding. And in these sorts of situations, that's where you might plump for using unfractionated heparin, because it's, if they bleed or if they need to go to theatre. So if they bleed, you can stop it and you'll be quite confident that within 45 minutes it's already dropped to half. And by 90 minutes, you've got very little unfractionated heparin left in the blood. Also, if you've got a really high-risk patient that's had a big clot, but they need emergency surgery, and you're worried about that, and you're worried about taking them off anticoagulation for surgery, then by giving them unfractionated heparin, you can anticoagulate them right up to the point, sort of 90 minutes before the operation is the only sort of time where they won't be anticoagulated. So that's where the short half-life can be really useful for unfractionated heparin. The other big use of unfractionated heparin clinically is that it can be reversed really effectively using, do you remember a drug we talked about last time?
We talked about protamine, didn't we?
Yeah, exactly. So protamine, which we can give to neutralize heparin, and it's really effective at neutralizing unfractionated heparin. It can neutralize 100% of it. And they use that massively in cardiothoracics, where they basically use unfractionated heparin. It's in the vein, it's quick, they can anticoagulate the patient and then get them on bypass. And then at the end, when they've done their surgery and the patient, they just want to close up the chest, then and take them off bypass, then they can reverse it really effectively and really quickly using protamine. So
Very nice.
Yeah. In contrast, low molecular weight heparin is all renally excreted. And as you said, it's only given subcut. And it has a half-life of more like 4 to 6 hours. So it kind of peaks at like 4 hours, and then it also has a half-life of like 4 to 6 hours. So what do you think might be the major benefit of low molecular weight heparin?
So I guess with its half-life, it's a lot more stable, a lot more easy to sort of, I guess, administer. You don't have to sort of worry about continuously monitoring.
Yeah, I think the key there is that we don't need to continuously monitor low molecular weight heparin. And that really boils down to a much more predictable pharmacokinetic profile. So with unfractionated heparin, those heparin molecules are really large and therefore they're really negatively charged. And what that means is they then want to bind lots of positively charged proteins that exist in our blood. So it means that, our blood is constantly changing in terms of the protein levels in our blood from one individual to the next. I might have more protein in my blood than you, for example, David. But then also, if I get an infection and I get a CRP rise, for example, I'm going to get more protein in my blood. It's going to bind heparin out of my blood even more. And when these other proteins, these positively charged proteins that aren't antithrombin 3, bind heparin, they effectively kind of neutralize the effect of the heparin. Do you get what I mean?
Yeah, no, absolutely.
So it means that it's a total nightmare in terms of you can't just give a dose of unfractionated heparin and know that it's going to cause X amount of anti-10A and anti-2A activity. So you don't really know, even within the same individual, whether that infusion that you're giving is causing a constant anticoagulant effect. And so that's really the crux of it, is that with unfractionated heparin, therefore, it requires quite regular monitoring of the anticoagulant activity that it is creating, because these big molecules are just, they just want to bind to everything. As in contrast.
So I guess, yeah, I feel like if
Yeah.
you were in theatre and you've got like
Yeah.
a point of care testing machine, you can sort of go, yes, they're definitely at this level. We're really happy.
Yeah.
We're doing all the things.
Yeah.
This is a quick onset. And also I can give a bunch of reversal very quickly, some protamine, and then I can sort of get out of there. So useful in the acute short term,
Super
but
useful.
actually giving the 40 milligrams that I give to more or less everybody in the world, probably not a great thing for long-term sort of VTE prophylaxis.
Yeah, exactly. So that's totally right. And actually, that's a good point, because we'll talk briefly about how you do an unfractionated heparin infusion using different monitoring methods. But for all of the unfractionated heparin that you ever use, or you ever are thinking about recommending to be prescribed, you need to think, where is this going to be carried out? Because it is intensive monitoring. It's tricky to get the levels and then to interpret them and then to adjust the dose. And a lot of the time it goes wrong. And, you only if you're heme reg on call, you'll know if there are lots of unfractionated heparin infusions going on, because you're going to get lots of phone calls about lab levels going wrong and dose adjustments and things. And it can be really dangerous. You can easily over anticoagulate somebody and cause a bleed. So really, unfractionated heparin infusions only should occur on wards where they're quite experienced with it. And usually that ends up being ICU, where you've got one-to-one nursing. And it's not used that much outside of that, other than in theatre, as you say. So the major benefit of low molecular weight heparin, in contrast, is that these molecules are really small. They therefore don't have the propensity to bind to all these other positively charged proteins in the blood. And as a result, you can give a certain dose based on weight, and you can be pretty confident, because of a very predictable pharmacokinetic profile, that they're going to get an expected amount of anticoagulation in their blood. And outside special scenarios like we talked about at the beginning, like extremes of body weight or renal failure, you're not really going to need to do monitoring of low molecular weight heparin. And as a result, as you say, that makes it perfect for low molecular weight heparin prophylaxis, because you don't want to be doing lab levels on everybody who has low molecular weight heparin prophylaxis, because that's like the whole hospital, and the lab would be totally overwhelmed. And also, it being subcut and only having to be given, once or twice a day is also really useful. So, really good. Has that cleared things up for you a bit in terms of the differences in your head of when to use one or the other?
Yeah, basically what I understand is if I'm going to give unfractionated heparin, I should probably speak to someone a bit more important than me first.
Okay, fair enough. If that's what, you're right in that you need to think about where it's being done, and what would be the clinical scenarios in which we do use unfractionated heparin.
A massive PE is the one that sort of really sticks out to me.
Yeah, exactly.
That's the only. Yeah, or would you use it in thrombolysis or?
No, thrombolysis, we'll do it as a separate podcast, but that's activation of fibrinolysis. That's very much like income blocker rather than anticoagulation. It's actually like breaking down clot that's already formed. So no, but unstable PEs, yes. And that's the kind of, it's almost seen as a middle thing. You've got your PE, which you could just anticoagulate with a low molecular weight heparin treatment dose, or if they're a bit unstable but not too unstable, you might go for unfractionated heparin and involve the PERT team. And then if it was really unstable, and they're really unwell, then that's when you would consider thrombolysis to break down the clot. So that's your sort of sliding scale of PE treatment. And then we said cardiothoracic bypass because of the rapid onset and the ability to fully reverse it at the end. And also interventional radiologists. So I've got a radiology friend who's an IR reg, and when they do things like EVARs, so aortic repairs and stuff, they're using quite a lot of unfractionated heparin because all these guide wires and stuff they're sticking in blood vessels. I guess they don't want them to clot. And then the other thing is, as we said, anticoagulation for a patient that's very high risk of bleeding, if they're in the appropriate setting, like intensive care or neurosurgery. And again, that's where you want to utilize on the short half-life and the possible reversal if they do bleed. So those are your situations for unfractionated heparin. So then what are the monitoring options? We've established that we need to monitor unfractionated heparin, and we've established when we would use unfractionated heparin, but what can we actually use to monitor it, to monitor the effect?
I'm hoping it's something to do with our APTT.
Yes, yeah, good, because
we mentioned it a while ago, saying that heparin is the APTT was invented to monitor heparin.
Yeah, exactly.
And then we got mad at everybody ordering it for other suspicious reasons. So
yeah, exactly.
That's my guess.
Yeah, exactly, because as we know, it's doing anti-2 and anti-10 activity, anti-10A and anti-2A activity, which are both in the final common pathway. But the PT isn't affected by heparin because we add the heparin neutralizing buffer, and that leaves us our APTT as our clotting test that we can use to monitor the effects of heparin. Good. When we take a blood sample for somebody on unfractionated heparin, it's really important that it gets to the lab urgently. It needs to get to the lab within an hour, and it needs to be centrifuged and tested within 4 hours. Have you any idea why? Has anyone ever said this to you before?
It hasn't been mentioned to me before.
Okay.
I wonder is this something to do with other cell degradation, releasing products that can sort of interact with it?
Yeah, really good. So platelets in a test tube release something called platelet factor 4. And platelet factor 4 can bind to heparin and neutralize heparin's effects. And so then if you have a test tube that's sitting around with the blood in it, and all the heparin will get neutralized. So by the time you test it in the lab, you might really underestimate how much heparin the patient's got on board. Yeah. Okay, so we use the APTT to start off with. What do you think might be a major disadvantage of using the APTT as a monitor of heparin?
So I guess we use it a lot. We've discussed things before, haven't we, about antibodies and mixing studies and stuff. So I guess it's not just specific to heparin.
Yeah,
it's gonna pick up any amount of other problems going on.
Yeah, exactly. So because it's testing that whole intrinsic and common pathway, anything that changes any of those levels is also going to affect your APTT, not just the effect of heparin. So if you've got a factor 8 deficiency, a lupus anticoagulant, or more relevant, particularly because we use unfractionated heparin mostly in critical care patients, is the fact that your factor 8 is an acute phase response, and it will massively go up in critical illness and infection. Also, when you have a big clot, you can get an acute phase response where your factor 8 massively goes up in response to the clot. And also in pregnancy as well. So in those situations, your factor 8 is going to go up and it's going to shorten your baseline APTT. And it's therefore going to result in you thinking that you're under anticoagulating your patient when actually that's not the case. So what the BSH recommend is that you must do an APTT at baseline before you start someone on unfractionated heparin. And if their APTT at baseline is normal, then you can crack on and you can use the APTT as a monitoring tool for your unfractionated heparin. But if your APTT is not normal at baseline, then they say that you shouldn't use that then to go on, and you're going to have to use an anti-10A level instead. Okay?
Yeah.
Then if we just have a quick look at a standard unfractionated heparin protocol, they look a bit scary, they look a bit complicated. There's lots of tables and lots of instructions, but essentially they're not as difficult as they look. You get a syringe of heparin, and you basically don't alter the dose of heparin in that big syringe and that pump. You just adjust the rate of infusion, a bit like your insulin in your like sliding scales and stuff, right? And you start with a bolus infusion, which is your loading dose, which you might leave out if they've got bad kidney function or a low BMI, or they're a really high bleeding risk, they're really frail or old or something. But most people will get a loading dose followed by immediately starting then the maintenance infusion with the pump. And then after 6 hours of that pump in being infused at a certain rate, dependent on their weight at the beginning, then you do an APTT and an APTTR. And then based on that result, you look at the table and you then basically adjust the rate based on whether your APTT is too high or too low to get you into range. And then you basically just have to check it again 6 hours post any dose change. And that's it. And then once they're stable and you've got them on a constant infusion rate and they've got an APTTR within range, then after that you can move to daily full blood count and APTT and APTTR monitoring.
What's the R bit again?
Oh, I'm really glad you asked that because I didn't explain that. So basically, that's just a way of sort of, so basically what it is an expression of a ratio of the patient's APTT to a normal APTT. And the normal APTT could be the local lab mean APTT that they've established, or sometimes it's just a fixed number of, I think it's 30.5.
Okay. Sounds like an INR is to a PT. Almost.
Kind of, but it's not as good as an INR because we're not using an ISI, the International Sensitivity Index, to make it standardized across labs.
Okay.
So it is a locally established thing, and there will be interlab variability. And sometimes if a patient does, in reality, not all labs have other tests set up other than an APTT and an APTTR. And if a patient needs to have unfractionated heparin and those are the only tests you've got available in the lab, then if I was phoned about somebody who did have an abnormal baseline APTT that was too short, for example, then what you could do is instead of giving them an APTTR range, which the range, the sort of the target range or the expected range, I should say, is 2 to 3 normally. Yeah. But if you had a really short APTT at the beginning, then you can just say, okay, that's fine. Just aim for an APTT that is 2 to 3 times above that baseline for that patient. Yeah.
Okay.
And that's a pragmatic solution to not necessarily having any other tests. And what do you think might be the most common? So I get a lot of phone calls for patients on unfractionated heparin with a really high APTT result, like alarmingly high. What do you think is the most likely cause for that?
But they're on unfractionated heparin.
They're on unfractionated heparin, but it's alarmingly high. Like it's way above 5. Patient's not bleeding. They look fine.
Okay, I no idea apart from the fact they're on something that's making them bleeding.
It's usually that they've taken the blood sample on the same limb that they've infused the heparin.
Okay,
So just bear that in mind. Think about your pre-analytical variables. If the test doesn't make sense in the first instance, just repeat it before you freak out.
This feels like the amount of times I've been given a VBG for someone who's on DKA protocol and it comes back with a potassium of 8 or something and I'm like, oh my God, and I run in there and then I'm like, where did you take this from? And they're like, oh, this ACF upstream of the potassium. I'm like, okay, yeah, good, fine.
Exactly, yeah, same thing. That's the way that probably most hospitals have been monitoring unfractionated heparin infusions, and they do a protocol based on the APTTR. However, the BSH paper kind of summarised quite nicely some of the evidence, looking at whether we use something else called an anti-10A level. And there were lots of different studies, but there was a retrospective study of 20,000 patients, and they looked at the use of either the anti-10A or the APTT to monitor the unfractionated heparin. And they found in that study that you were much less likely to require transfusions, which they controlled for age, gender, and other risk factors and invasive procedures and things, if you used anti-10A over an APTT. And there were also 2 other studies that showed that using the anti-10A resulted in a faster time to therapeutic range and fewer dose adjustments over that 24-hour period. So there is some suggestion that using an anti-10A is probably better than using an APTT. Overall, they looked at a meta-analysis of 10 studies, and it didn't show any difference in bleeding risk or thrombotic risk overall between the 2. But the BSH have said that if your APTT isn't normal at baseline, you should use anti-10A, and sort of seems to suggest that the anti-10A level is probably a better test if you've got it at your lab. So I guess this would be a good chance to just take a pause and just talk about the anti-10A assay. So the anti-10A level assay it is actually a useful name, and it's basically describing what it does. Okay, so remember how we always think about what's the aim of our clotting test, what's it trying to tell us? So the aim of the anti-10A assay is trying to tell us what amount of anti-10A activity is in the patient's blood as a consequence of some sort of drug that has anti-10A activity. So what are your drugs that have anti-10A?
So it's a measure of inhibition.
Yes, exactly. So a higher anti-10A level means you've got more inhibition of your 10A activity, and therefore probably a higher level of your anti-10A drug.
So mainly our heparins, so low molecular weight and unfractionated.
Excellent. Yeah. And then also,
good question. So would this be our DOACs?
Yeah, exactly. Yeah. So DOAC, so apixaban, edoxaban, rivaroxaban all have anti-10A activity. And then you've also got, don't forget, your synthetic pentasaccharide fundoparanox, which basically acts like low molecular weight heparin and unfractionated heparin, but it's just the 5 chain that's needed for the anti-10A activity. Yeah, good. Okay. So the concept of an anti-10A assay is you're taking citrated reference platelet pool plasma. So this is plasma you're getting from the lab, okay? And the reason why you're using that lab plasma is so you've got a nice constant source of antithrombin 3, because we know that for heparin, for example, we need antithrombin, okay? And it's also got other clotting factors in, like 2 and 5, to allow 10 downstream to then initiate a clot once 10 goes to 10A, yeah?
Yeah.
So you take your reference plasma, and then you basically take a known amount of factor 10A, and then you mix it with the patient's plasma. And the patient's plasma in this assay, the only reason for adding the patient's plasma is as a source of the anti-10A drug.
And it's almost like a reverse. It's almost like a reverse mixing study.
Exactly. Yeah.
Instead of adding all the bits in we need, we're adding an inhibitor.
Yes.
But exactly. To a known concentration.
Yeah. I actually think of it in my head a bit like a mixing study of like, okay, you've got your normal plasma, you've got with your antithrombin and your clotting factors and whatnot, you've got your known amount of 10A, and then you're just mixing it with your patient's plasma to see how much that known amount of 10A activity goes down. So then you just have to assay it. After you've mixed it and incubated at 37 degrees, you then just have to assay the amount of 10A that's left. And you can either do that through chromogenic mechanisms, like we did with the 2-stage chromogenic assay in haemophilia, like for example. So you could just use a chromogenic substrate that changes colour when the 10A is made to measure how much 10A is left. Or you can use the clotting-based method where you then do like an APTT-based factor 10A assay. So then I guess you just have to convert your anti-10A drop, your anti-10A level. You have to then convert that into, your heparin concentration. And you can do that by basically using a calibration curve where you have known amounts of unfractionated heparin that you add to plasma, and then a fixed amount of 10A, and you see how much the 10A goes down for known amounts of heparin. And you have to do these calibration curves specific to each drug you want to do an anti-10A level for. So for this one, it's unfractionated heparin, so I'd add different amounts of known unfractionated heparin, see how much it drops the 10A level by, construct a calibration curve, and then I can use that curve to extrapolate the patient's unfractionated heparin level based on their anti-10A level.
Yes, and that's specific to each lab, I suppose.
It is, yeah. Each lab has to do their own calibration curves and then, make sure that it's all validated. And our lab at the moment where I'm working, we have an anti-10A level set up for unfractionated heparin, but for low molecular weight heparin, but we haven't calibrated one for unfractionated heparin, and you can't just use the same calibration curve. You've got to do one for apixaban, one for rivaroxaban, one for unfractionated heparin, one for low molecular weight heparin. There are some commercial companies that now provide a combined unfractionated heparin and low molecular weight heparin calibrator. So you can add the concentration of that and then make a calibration curve with the anti-10A assay. But there's limited evidence for these. And the BSH paper says that if you're going to use a combined calibrator, that you must first separately validate each one. So, yeah. And then just a little bit extra, talking about platelet factor 4 from before. If we do an anti-10A level, we don't have to rush that to the lab in the same way that we did with the APTT when we're monitoring unfractionated heparin. So we had to rush that other bottle to the lab quickly within an hour because of the platelet factor 4 being released from the platelets in the tube. But when we're doing an anti-10A level, we use a substance often called dextran sulfate, which basically strips all proteins off of the heparin to measure it. And so it will also strip off platelet factor 4 that might land and bind and neutralize heparin in vitro.
Oh, okay.
So that's quite useful. But I mean, the disadvantage of using dextran sulfate is if you had a patient post-cardiac surgery, cardiac bypass surgery, and they've got a whole load of heparin that's been neutralized by protamine, and then you add dextran sulfate and you take all the protamine off, you're going to get a very high amount of heparin that, again, will be an overestimate of what's going on in their actual blood.
I guess it's useful from a pragmatic point of view of getting things through the lab, but it's less functionally accurate to what the in vivo situation would be to the patient.
Yeah. I think the best solution is, well, they don't, the BSH don't suggest a solution, and there is no real consensus between whether you should use dextran sulfate containing reagents or not. Either way, it's useful to know what your lab uses because then you know how to interpret it. Okay. So, and then if you do an anti-10A level, then again, the protocol for unfractionated heparin is very similar. You get a loading dose followed by an infusion, and your target range or expected range for your anti-10A level this time would be between 0.3 and 0.7. And then you can adjust the rate of heparin infusion based on whether you're above or below that level.
And I guess every trust will have their own protocol, which you just follow for that.
Yeah, exactly. Great. Yeah. And you can just Google a trust protocol just to see what one looks like and see how you'd work through it. It's something that I did do before I started my on-calls, just in case I was phoned about it. You don't want to be working out for the first time, in the night at like 3 a.m. So it's useful to have a look over one of them. Great. So I
imagine your wall in your bedroom looks very fun with lots of charts and protocols, just so you can fire them off at 3 a.m.
No, it's all in a folder, actually, David. I don't want it on my wall. Thank you.
Okay.
Okay, so we've talked about the APTT as a method of monitoring unfractionated heparin. We've talked about anti-10A. And then the third thing is this point of care test, which is called the activated clotting time. So we said that having a point of care test to monitor unfractionated heparin in theatre for cardiac bypass or in IR potentially, I don't know if they do. They do it in IR as well, is that you need to know quite rapidly whether the patient is adequately anticoagulated so that you can then get them onto the bypass machine. Because obviously, if they're not adequately anticoagulated and you put them on bypass, the whole thing is going to clot off and it will be a disaster.
Yeah.
So I know this mainly from my anaesthetist husband, but basically what they do is they basically give the patient a big bolus of unfractionated heparin and they check the activated clotting time at baseline on the point of care machine. They then give the big bolus of unfractionated heparin, and then 3 minutes after they've given that bolus, they then check an activated clotting time again. And they different trusts will have different cutoffs, but it's roughly around 400 seconds. It needs to be above 400 seconds for them to be happy that the patient is adequately anticoagulated. So if it's not there, then they give them a top-up dose and check it again in 3 minutes' time. And then once they're above 400, then they proceed and they put them on bypass. And then they check it every 30 minutes to make sure that they're still adequately anticoagulated. And then at the end, they before they take them off bypass, they then give the protamine sulfate to neutralize and reverse the unfractionated heparin they've given. So they basically calculate the total dose of unfractionated heparin given throughout the whole operation. And then they give the appropriate corresponding dose of protamine, which is dosed at 1 milligram per 100 units of unfractionated heparin activity. and then they actually use TEG because they love TEG, and they do a they do a TEG pre and post protamine to make sure that there's a difference in the traces, basically. And if they're happy that therefore it looks like it's all been reversed, then they take them off the bypass machine. And it's a similar thing in interventional radiology, but I think they anticoagulate them to a lesser degree. So I think the range they look at is more like 200 seconds. We, as haematologists, should probably just know a bit about how that point of care test works. So it's a point of care test. So this isn't citrated blood. This has not gone into a blue top bottle. It's whole blood, okay? And so we take whole blood, and then basically the clotting cascade in the machine is activated by using a contact surface activator. So activating basically the intrinsic pathway. And then we basically just crudely measure the time taken to clot. So it's still in my head using the APTT, but just a really crude point of care version of it.
Yeah.
What do you
think?
It's
almost like a bleeding time, but in a
Yes.
test tube.
Yeah, exactly. Yeah, it's pretty raw, but they just need
Yeah.
the priority here is just having a point of care test so they can just.
I guess it reflects probably what the patient's doing pretty accurately.
Well, yes and no, because obviously it's not just going to be the heparin level.
Oh yeah, there's
there.
going to be platelets and all other kind of anticoagulants and whatever else is in there.
Yeah, exactly. The temperature of the patient. Yeah, factor deficiencies, lupus anticoagulant. It's vulnerable to all the same interference of that of the APTT, plus more, because what's your source of phospholipid in this case?
The patient's?
Yeah, the patient's platelets surface.
Yeah.
So therefore, the activated clotting time will vary depending on how many platelets the patient potentially has. So that's one.
Yeah. I guess if they're having massive hemorrhages as well, they're hemodiluting them with lots of fluids and things. So potentially very hard to predict what the actual, heparin action is.
Exactly. And also the source of calcium, again, is just going to be the calcium that they have in their blood rather than something that we add in the lab in a more controlled manner.
Mm-hmm.
But, it does its job. It's useful to be used in that context. So, yeah. Okay. And then, do you have any questions first before we just briefly touch on a bit more about low molecular weight heparin and how we might monitor that in contrast?
I guess maybe some practical advice on terms of, my 140 kilogram man has come in and I've ordered these tests. What should I be looking out for and what should I be doing if those come back and they're wrong or, it gets flagged up that this is after my anti-10A, it's out of range.
Okay, that's good. So you're basically asking how we monitor low molecular weight heparin. And we've said that with low molecular weight heparin, we basically don't need to monitor it so much because it's got the predictable pharmacokinetics. But there were certain situations, and your example is extremes of body weight, where we may well want to do an anti-10A level. And the anti-10A would be the best thing to do. And the thing about... unlike an unfractionated heparin, where it's a continuous infusion and the timing doesn't matter so much about when you collect the blood sample. I mean, obviously, 6 hours post a dose change, but it's not like super critical in terms of, well, it's a constant infusion, isn't it? But with low molecular weight heparin, obviously you're getting a peak and a bit more of a trough because you're getting that once a day subcut injection, and it will peak after like 3 to 4 hours and then it will go back down so that by the time you do the next injection, it's quite low. And so you need to think about before we even think about the anti-10A, you need to think, okay, what is my question? Am I concerned here that the patient is not anticoagulated enough? Is the concern about efficacy? For example, if I'm phoned about a patient on low molecular weight heparin, they've usually got cancer and they've got a recurrent thrombosis. Am I worried that actually they're not on the appropriate dose for whatever reason? Maybe their weight has changed, or for whatever reason, they're not anticoagulated in the way that I would expect. So is it an efficacy concern? Or like in the obese patient, am I giving them enough drug given they're so heavy? Or is it a concern about accumulation? Is it a renal patient where I'm actually worried that they're accumulating heparin and they're actually, they're too anticoagulated, and that will affect when you want to take your anti-10A level. So if I was worried, David, about efficacy, when do you think might be a good time to collect an anti-10A level?
So if I'm worried about a person who's overweight, and we sort of said, what did we say the get start time was for the low molecular weight?
So
We said it was.
it peaks at 3 to 4 hours.
So I'd like it at 3 to 4 hours, yeah. And then for my renal person, I want a trough level.
Really good, exactly.
Yeah.
So you want it 3 to 4 hours, and you want it post at least the third dose of heparin, just so that
Okay.
it reaches some sort of steady state. I mean, I don't exactly understand that, but at least after the third dose, and 3 to 4 hours post that third dose is when you would collect your level if you're looking for efficacy. And if you're worried about, as you said, renal disease, then it's your trough. So just before your next dose, but don't hold your next dose. Give it as soon as you've got the blood test taken. Yeah.
Yeah.
Good. So the timing really matters. And then basically, if it's your sort of range, your expected level for once a day dosing of low molecular weight heparin is about 1 to 2. So it's quite an easy sort of number to remember. If it's twice a day dosing, then it's 0.5 to 1. And so in some places, they split the dose, particularly if they're worried about bleeding, they might split the dose to BD dosing. So they take the total dose and divide it by 2 and give it morning and evening.
Yeah.
Benefit of that, I guess, is there's less of this peak and trough. And that's why your target range is lower at 0.5 to 1. Disadvantages, actually, if you've ever had enoxaparin injections, which I had after my section, they are genuinely really they sting quite a lot. I'm not going to lie. So you've got to think about compliance it's the balance between compliance and this idea of, peaks and troughs. Different
Yeah.
places will have different views on that generally.
I completely agree. I know our trust is BD if you're over 100 kilograms. And as a 104 kilogram man, I will tell someone that I'm 99.9 if I get admitted.
Yeah, yeah, exactly. Although you're nowhere near that weight, but yeah. Yeah, and then your trough level should be, probably less than 0.3, or between, they say for VT prophylaxis, the range is 0.1 to 0.4. So,
Okay.
yeah. Okay, so that's when you would do your anti-10A, and just remember, it's exactly the same as the methodology we talked about for unfractionated heparin, but you need a calibration curve for low molecular weight heparin to make it valid. Yeah.
That's good.
Okay, and that's the only test you would use to monitor low molecular weight heparin. Should we talk about why people might be put on low molecular weight heparin? Because we talked about why we would put people on unfractionated heparin, but when do you see people on low molecular weight heparin?
For the vast majority, it's VTE prophylaxis.
Yeah, absolutely.
I would say it's 99% of what I do.
Yeah.
And then treatment dose is often for things like PEs, I guess stable PEs to make that difference.
Yeah.
And then some of the ACS treatments involve, if they come in on a Pixaban, I've often put people on enoxaparin as part of the ACS treatment as well.
Okay. Yeah. So, yeah.
And paroxysmal AF. There we go. I'm firing them off now.
No. So basically, for any sort of VTE or clot risk, where you're treating a VTE, we often start with low molecular weight heparin treatment dose for an acute VTE, just because it's got a shorter half-life than some of your DOACs. And you might then transition to a DOAC once you're happy that they've not bled and that they're relatively stable. That's usually why we go for low molecular weight heparin first, but then with a view to transferring over to a DOAC, because DOACs are okay in cancer now. They've been shown to be non-inferior to treatment dose low molecular weight heparin. And remember that 2 of your DOACs, the edoxaban and dabigatran, you should have treatment dose low molecular weight heparin first anyway for 5 days before you transition to a DOAC. So I would say the majority of the use of low molecular weight heparin is either VTE prophylaxis or treatment of VTEs in the initial stage before you transition them onto something else. Okay, and then in terms of dosing, obviously each trust has its own protocol and its own type of low molecular weight heparin. We use enoxaparin where I work at the moment. And I would say I get a lot of phone calls because of the case that you started with at the beginning of this chat, about where it says phone the haematologist because the patient's over the reference range. And the problem is, as we said at the beginning, it's an evidence-free zone. So it's quite difficult because, you end up giving advice based on generally what the consensus feel is, but there's nothing out there that you can really hang your hat on. In general, for prophylaxis, we increase the 40 milligrams once a day to 40 milligrams twice a day once they're over 100 kilograms. And then once they're over 150, where I work at the moment, we actually increase to 60 milligrams BD. And in terms of renal failure patients or really low weight, less than 50, then it's just 20 milligrams once a day. And in those extremes of weight, that's where you'd be looking at then doing an anti-10A level. And then in terms of treatment, what we do in our trust at the moment is if they're over 110, so if they're between 110 and 120 kilograms, we do 180 milligrams once a day. And if they're over 120 kilograms, then we do 1 milligram per kilogram dosing BD. And in renal failure, generally the consensus is for treatment dose, it's 1 milligram per kilogram once a day.
Got you.
Yeah. That's all I really wanted to say about heparin, unless you have any other questions about it, David.
No, not from me.
Okay, shall we wrap up then?
Yes, friend.
So, I guess our key learning points are that, well, firstly, unfractionated heparin, the major advantage of it is the short half-life and the easy reversibility. And that's why we use it in high-risk bleeding, clotting situations and in like cardiothoracic surgery. And if you're going to set up an unfractionated heparin infusion, just think about where you're doing it and whether the ward that the patient is on, that the staff can manage that safely, because it's quite labour intensive. And that if the APTT is normal at baseline, then it's still okay to use an APTTR-based protocol for unfractionated heparin. But if it's not normal, then really we should be using the anti-10A assay. We talked about the anti-10A assay and how this is basically using the patient's plasma to reduce a known amount of 10A activity to know how much drug activity they've got going on in their blood. And we touched on how important it is that the anti-10A assay is calibrated to the specific drug that you're assaying. So it's really important when you send an anti-10A level that you do tell the lab what drug they're on, whether it's unfractionated versus low molecular weight heparin even. And then we talked about low molecular weight heparin and how the pharmacokinetic profile is much more consistent, and that's because the molecules are much smaller, so they don't just bind to loads of random protein in the blood, and therefore we don't really need to monitor low molecular weight heparin unless there are specific things, usually due to extremes of body weight or renal failure, and we need to make sure that we do the correct timing of the anti-10A level. So 3 to 4 hours post third dose is the standard advice if we're looking at the peak for efficacy.
Lovely.
Great. All right. Well, that was a lot of chat about heparin. I can't believe how long we've managed to talk about that.
Yeah, I thought the answer was 40 milligrams once a day, and that's all you do.
But hopefully that's covered a broad range of things that you might get called about as a haematology reg.
Yeah, have things in a folder, not on the wall. Got it.
Yeah, thanks, David. It sounds really weird. Okay, so we'll see you guys next time. Thank you so much for all tuning in and listening and following along and leaving ratings. And yeah, we really appreciate your support.
Yeah, just on that note, if you do want to get in touch with us, we mentioned at the end of the last episode, we've got an email address up and going now, which is basics2brillianceheme@gmail.com. If you've got any questions that you're too afraid to ask the consultant, that you can bounce towards our resident haematology registrar. We'll be happy to put those together into a session at some point. We're also getting up our other social media platforms. So on X, formerly Twitter, we are basic_2, that's the number _brill, and then on Instagram we're basics to brilliance. If you want to follow us, that'll be cool. If you want to contact us that way, that's also fine. We just want to hear from you. If you've got any questions, we would be happy to field them.
Yeah. All right.
See you next time.
Bye.
Bye.
Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time!